Telemedicine has bridged the gap in healthcare delivery, especially in the areas of internal medicine, where chronic and lifelong care is very much needed. Good afternoon. I am very much honored to be invited as one of the speakers for today's breakout session to give an updated and up-close view in the practice of telemedicine in endocrinology today. The new normal can be a better normal. It's always good to have options, and I think you will all agree that telemedicine becomes a supplementary button in your practice. My talk for today will cover telemedicine and endocrinology, common thyroid disorders, diabetes and metabolic syndrome, and other common endocrine online consults. Also, I will discuss the flag signs of endocrine emergencies. What are the benefits of telemedicine? With telemedicine, we are given access to specialized care. There is also elimination of unwanted travel and absenteeism. In an article published in 2018 by JICA, Filipinos lose 9 to 15 years of their lives in traffic. And this problem will worsen as we foresee further opening of the economy in the next few months. Also, telemedicine helps us monitor lifestyle changes of our patients. It helps us triage symptoms, and it helps us reduce hospital admissions. The marriage of telemedicine and endocrinology has proven to be a successful one, and this is because of the following reasons. Most diseases covered by an endocrinologist are chronic non-communicable diseases. There are just few endocrine emergencies. The severity of condition correlates well with the laboratory test, and monitoring devices and smart apps are compatible adjuncts to telehealth. It is very much true that opportunities are born from crisis. The pandemic has reshaped the landscape of endocrine healthcare. Face-to-face care will remain important, but teleendocrinology is here to stay. Although we are continuously overwhelmed by the COVID-19 pandemic, we should always recognize the double burden of diseases, and these are the twin deficits in medicine: the scourge of communicable and non-communicable diseases. Just for example, in the year 2020, somehow we have an idea that about 3.3 million died because of COVID-19 infection. However, we tend to forget that in the same year, there are about 320 million of people who died because of cardiovascular diseases and diabetes. Look at our data. The prevalence of diabetes is 7.9% according to the latest 2018 FNRI survey. This will be much larger if we will include patients with prediabetes. Likewise, the prevalence of thyroid diseases is also high, at 8.5%, according to the PhilThyroid survey in 2008. How about the prevalence of obesity? According to FNRI, 37.2% of the adult population is obese. In reference, 19.2% of the adult population has hypertension. It is also important to point out that most of these chronic diseases are already affecting the productive age group of our society, or the working age group of 15 to 64 years old. And with telemedicine, they will benefit the most because they will maintain their productivity, and at the same time, they will be able to address their illnesses. It is always a fundamental rule not to give the burden of technological operations to the patient. The physician must devise an efficient flow of engagement and interaction to the patient. The physician must choose platforms and devices that will enhance productivity and comfort for the patient. He or she must assign roles to the office staff or secretary, as well as top support system of the patient to maximize consultation and continuing care for the patient. This is a teleendocrinology sample workflow. The major components of the consultation will be the following: scheduling the patient, the pre-consult, the consultation proper, and the post-consultation period. In scheduling, the physician or the secretary should be able to screen the patient, set appointment, set instructions, accomplish consent and other forms, and set the payment method. In the pre-consult, the patient and the secretary should provide checklists, review forms, records and referrals, laboratory, medications, and assist the patient and relatives in the connectivity. During the consultation proper, the physician should review the forms, evaluate the patient, and provide and discuss the assessment and plans. After the consultation, There should be completion of documents, sending of reviewed prescriptions, and the patient must acknowledge that he or she understands what were discussed during the consultation and what were sent in the post-consultation period. During the consultation proper, we must always look eye to eye to the patient. Therefore, we should always, or most of the time, look at the lens of our device. We are encouraged to use plain background. We need to adjust our camera from our chest up. And we should always ask who is with or who are with the patient. Because most of the time, we need to discuss our plans not only to the patient, but also to the relatives. The patient will be asked to perform provider-directed self-physical examination. And also, we need to review and ask patient self-monitored parameters, such as blood pressure, blood glucose, and anthropometric data. We need to discuss the laboratory results of the patient, especially the abnormal ones, no matter how trivial they are for us, because sometimes it provides anxiety on the part of the patient to see that there are abnormal labs in his or her report. And then, finally, we should use screen sharing tools to maximize explanation and to provide patient resource materials. The cardinal rule is to always hear the patient first before going into the laboratory findings and before discussing your further plan and management. The patient should have his or her own time to vent out his main complaint. As physician, we must be familiar and we should be able to educate and train our patients to use peripheral devices. We should also be familiar with the available websites that will facilitate our referral system. Likewise, there are some websites which can be used as source of patient brochures for their education and continuing support system. Let us now discuss the common endocrine disorders that you may encounter in your practice of telemedicine. First will be the thyroid disorders. The thyroid gland is the only endocrine gland that is accessible to physical examination. And even with virtual consultation, we should be familiar on how to maximize inspection of the neck of the patient and the thyroid, as well as how to perform maneuvers that can enhance the clinical diagnosis of thyroid diseases. Here are some endocrinology pearls that you may want to know when dealing with patients with thyroid disorders. During the pre-consult, you are advised to have checklists of the different signs and symptoms of thyroid dysfunction. You can also provide the patient with a video on how to do self-thyroid physical exam so that the patient can report to you his or her findings and you will verify it during the consultation proper. During consultation, you might want to be familiar with the scoring system, especially Birch scoring, which helps you determine which patients have impending thyroid storm and may need face-to-face or emergency room consultation. You should be able to perform thyroid physical exam maneuver on screen. During the post-consultation period, you need to provide the precautions for the medications that you prescribe for the patient. And also, patient brochures will help, as I will show later. In the continuing patient education part, websites and Facebook pages may be helpful for individuals. As healthcare providers, we are in the best position to give reliable sources of information for the patient. Oftentimes, it is helpful to send a video resource for the patient on how he or she can perform self-physical examination of the thyroid beforehand. This is an example of a simple thyroid physical exam video you might want to send to your patient.
To get started, what you'll need is a mirror and a glass of water. First, look in the mirror and tip your head back. Second, drink some water, swallow, and watch your thyroid move up and down. Men, you want to look between the collarbone and the Adam's apple. You want to look for any lumps or bumps when you swallow. Women, the Adam's apple isn't as visible. You want to look from the collarbone up. You will want to repeat this test several times.
Let us use a common case for example. This is a case of a 27-year-old female who complained of palpitations. How will you go about with the online consultation? During the pre-consult, it is helpful to provide the patient beforehand with a checklist of symptoms pertaining to thyroid dysfunction. And of course, you might want to ask the patient for the available laboratory tests in the recent past. In the checklist, you will include symptoms such as weight changes, temperature intolerance, eye changes, perception of neck mass, menstrual changes for females, palpitations, tremors, difficulty of breathing, family history of thyroid diseases, and of course, previous thyroid surgery or radioiodine therapy. Do you know that we have our own UST scoring index for hyperthyroidism? And this was validated in 2010 by Dr. Gaya et al. And this scoring index can already be used as your pre-consult form, and it can be verified during the consultation proper. During the consultation proper, it's very important to rule out impending emergency of thyroid storm or severe hypothyroidism. Here, we look for sensorium, signs of heart failure, fever for thyroid storm, as well as jaundice. If this is ruled out, then we can proceed with the consultation proper. Always ask for the onset and duration of symptoms of the patient. Ask for recent associated illness, as these may affect your thyroid function testing later on. You should also ask for thyroid or antithyroid medication or any other medication and supplements such as iodine-containing supplements like amiodarone, as this may later on affect our interpretation of the thyroid function test results. It is always imperative to ask for previous thyroid surgery or radioactive iodine. For female patients, we need to ask their OB/GYN history, and for both, we need to ask for their plans of having children in the future. In the physical examination, we need to be a keen observant on the mood of the patient, as hyperthyroid patients tend to be agitated and anxious, while hypothyroid patients, of course, they are in a depressed and low mood. We need to check their habitus, whether they are overweight or obese, as these are common in hypothyroid patients. And if they recently lose weight and they are thin, then a possibility of hyperthyroidism is there. We need to check their clothing, as this will provide us with information on their temperature intolerance. And of course, their voice, especially if they have lumps in their neck, as these can be sign of obstruction or, at the extremes, malignant thyroid condition. For the extremities, we ask the patients to raise their hand like this, and with good resolution, you can appreciate fine tremors of hyperthyroidism. And we can also check for muscle atrophy, especially in hyperthyroid patients. Muscle weakness, nail changes, pretibial mixed edema, as the one presented on the right of your screen, and also edema, which can be found in patients with thyrotoxic heart failure, as well as in patients with severe hypothyroidism. Remember that the normal thyroid gland is usually not visible, but it is palpable. However, we don't have that luxury in online consultation. Therefore, the best we can do is to grade the patient according to the WHO category. Grade 1 for not visible, grade 2 for visible when hyperextended, and grade 3 visible even not hyperextended. So our patient seems to have a more prominent right thyroid lobe. So there's a questionable nodule in the right thyroid gland. Although some patients with diffuse goiter can also present with asymmetric thyroid enlargement. Because we cannot palpate the thyroid of the patient, this is a limitation in our examination. However, in order to maximize our physical examination, we may also perform some maneuvers. So how can we make the possible right thyroid nodule of the patient more prominent during physical examination? One is to ask the patient to swallow water, as you have watched in the video. It will make the nodule become more prominent. And number 2, you ask the patient to look on the contralateral side of the suspicious nodule. In our case, the patient has a nodule or a suspected nodule on the right lobe. So we ask the patient to look on her left side so that the right neck will become more prominent. And while swallowing, the suspicious right nodule will become more prominent. There are also eye signs we can elicit during physical examination. But for the sake of inspection, we need to check for lid retraction or obvious exophthalmos. If this is not so obvious, we can perform the lid lag maneuver. We ask the patient to follow our finger from top of the screen, then slowly downward. A positive lid lag is present when the upper eyelids will lag behind eyes' downward movement, with the sclera being visible between the upper lid margin and corneal limbus. And now we are ready to make a clinical assessment for our patient. She is a 27-year-old female who complained of palpitations and weight loss. There is also heat intolerance and irregular menses with positive family history of goiter. The patient is agitated during the online consult, but she speaks in sentence, so there is no sign of distress, and an impending thyroid storm is unlikely. The patient knows how to take her blood pressure and heart rate. It was 120/60, and the heart rate is 104 beats per minute. She was also able to take her temperature. She has no fever. She knows her weight, which is 43 kilograms. She has a wide stare. And because you can see the thyroid, even when her neck is not hyperextended, it is described to be grade 3. And the right is more prominent than the left, so you are still suspecting of a nodule. So our clinical assessment is nodular toxic goiter, which can be a toxic adenoma or a Graves' disease with nodule. We will discuss this to the patient, and of course, we will lay out our diagnostic plans. For our diagnostic plans for this patient, we need to establish the thyrotoxic condition or the hyperthyroid state. For patients with primary hypothyroidism, which is the most common cause of hypothyroidism, TSH is elevated and T4 and T3 are low. While for your patients with primary hyperthyroidism, TSH is low and your T3 and T4 are elevated. And this is the expected finding in our patient. More than 95% of thyroid axis disorders is caused by thyroid gland dysfunction or primary thyroid dysfunction. Therefore, it should fall under one of the 4 categories. Overt hypothyroidism, patients with high TSH and low T4 and T3, subclinical hypothyroidism, patients with high TSH and still normal T4 and T3, overt hyperthyroidism, patients with low TSH and high T4 or T3, patients with subclinical hyperthyroidism, patients with low TSH and still normal T4 and T3. But there are patients that will present with discordant results, meaning it does not fall under any of the 4 categories mentioned. For these patients, you need to review any missing data in the history. Like for example, recent intake of thyroid hormone, iodine, or recent antithyroid medication, as this may affect acutely your T4 and T3. Recent surgery or radioactive iodine therapy. There is still no steady state in the hormonal status of your patient. Or patients with recent illness, they can also present with what we call CQ thyroid syndrome or non-thyroidal illness. Some medications, especially in the ICU, such as steroid or pressors such as dopamine, can actually affect the thyroid function test. More so, amiodarone, which is iodine-containing, can acutely affect your thyroid function test. Also, one should always consider an assay error or a non-sensitive assay, especially if you know that they do not use the 3rd generation or high-sensitive TSH assay. And finally, the more complex hypothalamic or pituitary disease. For any of these conditions, you might want to repeat the thyroid function test, or you might just want to refer to your endocrinologist. Going back to our patient, since our patient present with a suspicious right thyroid nodule, we also requested for a thyroid ultrasound, and it showed a 3 by 2 centimeters solid mass on the right thyroid lobe. For cases like this, in which you have 2 differential diagnoses, one is Graves' disease with nodule, and the other one is toxic adenoma, it will be beneficial if we will order additional tests, specifically your thyroid uptake and scan. The thyroid uptake is a quantitative test that will tell us the hyperactivity of the gland, while the thyroid scan, which is much useful in this patient, will tell us whether the nodule appreciated in the physical exam and seen on the ultrasound is actually hyperfunctioning. And in this case of our patient, there is an increased iodine 131 uptake and a hyperfunctioning nodule on the scan. Therefore, our diagnosis is toxic adenoma. Now that we have completed our online history taking, physical exam, and follow-up laboratory tests for this patient, we have our complete diagnosis, which is toxic adenoma. And all that were mentioned should be documented in our electronic medical record. With the proper diagnosis, we are now ready to give the treatment plan for our patient. And these are the following: to address the symptoms of the patient by giving a beta blocker, address pathology and discuss goals. So for our patient, we need to make the patient euthyroid by giving antithyroid medication. But this is a toxic adenoma, so it will not have a remission with antithyroid medication alone. So later on, we need to ask the patient whether she wants radioactive iodine therapy or surgery. Likewise, we need to address the possibility of treatment-related complications because, as you all know, there are possible complications in giving antithyroid medications. Also, since the patient presented with weight loss, we need to address diet and nutrition. We also need to address the myths and fallacies related to thyroid diseases. These are the following we need to do after the consultation. We need to send the electronic prescription. It is also valuable to provide a feedback evaluation form, and of course, the follow-up reminder for the patient. In this case, we furnish the patient with a prescription bearing specific instructions on when to take the medications. We need to inform the patient about the precautions of taking the medication, such as for methimazole. We ask the patient to report if there are rashes, fever, or sore throat. We ask the patient to record her weight gain and also the menstrual period, because remember, this patient presented with irregular menses and she is of reproductive age, and the follow-up instruction after 1 month. The laboratory request should also be sent to the patient. Also, we need to indicate future plans if we think that the patient will be better on radioactive iodine or surgery. I find it useful and rewarding to send patients resource material from reliable institutions. For example, I can send the patient a brochure from the American Thyroid Association. These are the common questions they will ask if they have hyperthyroidism. I can send them the link of the brochure, or I can send them the QR code, and they can read that, and if they have questions, they can get back to me. If I have plenty of time in the future, I want to translate these brochures in our language so more patients can easily understand the content. Also, if there are difficult cases, I can refer them to multi-specialty or advanced care centers, such as our very own section of Endocrinology, Diabetes, and Metabolism. We have our Endocs Teleconsult. For example, our patient may need radioactive iodine therapy in the future. I can just directly refer them online to our endocrinology service through this Facebook page. I can give them the link, or I can give them the QR code, and I can endorse them to our fellows. So that makes the continuity of care for our patient easy and efficient. So what are the common thyroid cases you will encounter in your practice of internal medicine? For example, this is another 27-year-old female who presented with just high TSH for her regular follow-up. The patient was diagnosed of post-surgical hypothyroidism, and she is on levothyroxine. But this time, her TSH is 6.5. It is high. And you are thinking that you need to adjust the medications. So before seeing the patient online, you might want to send checklists for the patient. In addition, you might want to include in your checklist the compliance questions of the patient, such as the timing and the food intake before or after taking the medication, as this may affect the absorption of your levothyroxine. You might want to ask for weight change of the patient because, as we know, most hormones are computed in reference to their weight. And of course, if there is pregnancy, because you need to adjust the dose of levothyroxine. Likewise, some patients would take over-the-counter supplements such as iron and calcium. And if taken with levothyroxine, it can affect the absorption of this hormone. How about this 42-year-old female with neck mass, like our first patient, but this time there is no hypo or hyperthyroid symptoms? Our diagnosis is nodular non-toxic goiter this time, and the minimum tests that we need to request are your thyroid ultrasound and your TSH. Of course, if there is even a slight suspicion of hypo or hyperthyroidism, you are asked to request for your FT3 and FT4 as well. But because you did a good history and physical examination, though online, you are able to diagnose that the patient has no signs of hypo or hyperthyroidism. And you only requested for a thyroid ultrasound and TSH. And the patient was able to save around 2,000 pesos because you judiciously selected the diagnostic test. So your TSH turned out to be normal, and your ultrasound showed a 3 by 2.4 centimeters solid hypoechoic mass on the right lobe with smooth border and microcalcifications. So the question now is, when is referral for biopsy indicated? Nowadays, our friendly radiologists use your thyroid scoring. In this scoring system, they compute for the score using the composition, echogenicity, shape, margins, and echogenic foci inside the nodules. And they will compute the total scores from these categories. And the total score will tell us whether the nodule is suspicious or not. And with the corresponding score, Each nodule will be interpreted with degree of suspicion for malignancy. The size will dictate the threshold for fine needle aspiration biopsy. Our patient has a thyroid score of 6, and based on this category, our patient deserves a fine needle aspiration biopsy because it is moderately suspicious and the size is above 1.5 centimeters. Don't worry, our radiologists usually report their score and their recommendation at the bottom of the ultrasound report. Now that we have covered the most common thyroid diseases, let's go to the next bread and butter of endocrinology, which is diabetes and metabolic syndrome. The burden of diabetes affects 3.7 million Filipinos. There are about 100 diabetes-related deaths each day, and an average Filipino with diabetes spends 11,700 pesos each year for diabetes-related expenditure. This is around 5% of average annual income per family if only one member is affected. So what are the teleendocrinology online pearls you may want to know about diabetes mellitus management? During the pre-consult, you might want to provide the patient with the following: checklist of signs and symptoms, tabulated weight gain and capillary blood glucose monitoring, weight, height, and BMI if possible of the patient. During the consultation proper, you need to demonstrate the proper diet using the plate method. Ask the patient to return a demonstration on insulin injection and blood glucose monitoring if necessary. In the post-consult, you might want to furnish your patient with an individualized diet, an exercise video, and other video resources that you find useful for the patient. For the continuing patient education part, you can use QR codes, you can use websites and pages. So let us use another case. This time, this is a 48-year-old male who complained of recent weight loss. During the pre-consult, you need to provide the patient with checklists and all other forms that he or she needs to accomplish. Checklists for diabetes and metabolic syndrome are as follows. You need to document the risk factors of the patient, the duration of the disease, the comorbidities, the complications, the current medications, the blood pressure and heart rate taken by the patient, as well as the waist circumference, weight, blood glucose monitoring if already available, and also recent laboratory tests that may be valuable in your management of the patient. A simple guideline or checklist that you can use will be from our very own Unite for Diabetes Clinical Practice Guideline. It enlists all the possible risk factors of the patient with diabetes, and you might want to use this as a checklist for your patient. Our patient is an obese patient with recent weight loss, patient with hypertension, and a patient with previous fasting blood glucose of 119 milligrams per deciliter 3 years ago. Aside from risk factors, we need to also check for complications of our patients and possible comorbidities, as well as the medications they're currently taking. We need to review all possible complications, such as your macrovascular complications, coronary, cerebral and peripheral arterial diseases, their symptoms and the medications they're currently taking, microvascular complications such as retinopathy, neuropathy, and nephropathy, their symptoms, and if they're currently taking any medications. So our patient do not have any prior CVD event, but he complains of blurring of vision, and the patient is already on amlodipine for hypertension. In the physical examination, it is important to take a look at the cognition and orientation of the patient, as we need to rule out hyperglycemic crisis. And usually, patients with impending hyperglycemic crisis present with sensorial changes and weakness. They sometimes also present with respiratory distress. We also need to rule out other possibilities of concurrent infection, as this will warrant admission of the patient and not just focusing on the management of the diabetes. If these conditions are all ruled out, we may proceed with our physical examination. We need to ask for the reported visual acuity of the patient. We check for the hydration status somehow, and if there is a possibility of anemia, especially in patients with a chronic kidney condition. And then we ask for their reported vital signs, including your blood pressure, heart rate, and temperature. And we can do some form of inspection to estimate the respiratory status or respiratory rate of the patient. For the anthropometrics, we can ask for the weight, the height, and the waist circumference of the patient. A valuable tool in my practice is to use the Asian BMI calculator by the Joslin Diabetes Center. For example, in our patient, the height of our patient is 5'7", so we can put it in our calculator. And our weight is 78 kilograms, and we can calculate his BMI. His BMI is 26.9, and it is above the healthy range. So the patient can actually know that his weight is above the healthy range, and he would know the basis of your weight loss management. So some patients, especially Filipino patients, have normal BMI, yet they have abdominal obesity. And so we emphasize to them that despite having normal weight or BMI, if their waist circumference exceeds 35.5 for males and 31.5 for females, they are still considered having abdominal obesity, and they are at risk of diabetes, or their diabetes will worsen if they don't participate in active, healthy lifestyle management. We need to also check for some forms of edema, skin discoloration, wound lesions in the extremities. Likewise, we would check for acanthosis nigricans and dermopathy, which are also signs of diabetes mellitus. We also want them to submit their self-monitored blood glucose monitoring beforehand. For the extremities and skin lesions, you might want them to have a photo of these complaints or these signs beforehand so that they can prepare it in a well-lighted setting, and you can appreciate the lesion better. So our patient has a blood pressure of 140/90, heart rate of 78, weight of 78 kilograms, height of 5'7", as we have computed his BMI, which is 26.9, waist circumference of 41, which is above the cutoff for Asians. And there's a presence of acanthosis nigricans, a sign of insulin resistance. So we are now ready to make a clinical assessment for this patient. So this 48-year-old male presenting with recent weight loss, but despite that, he is still under the obese 1 category, who also presented with polyuria, blurring of vision. He is already a hypertensive with previous impaired fasting glucose result and living a sedentary lifestyle with a positive family history of diabetes with the following physical findings. Then we can make an assessment of metabolic syndrome because the patient is already hypertensive. The patient has previous impaired fasting glucose, and the patient already presented with abdominal obesity, considering the waist circumference. Also, he is now a DM suspect with probable complications because he already presented with blurring of vision. Of course, the patient is already hypertensive and obese class 1 using the Asia Pacific guidelines. So more or less, we have the full diagnosis, but we need the confirmation of laboratory tests, as well as we need to request for the laboratory test to detect other complications. These are the goals of requesting for laboratory tests. First is to establish the diagnosis using the appropriate laboratory parameters. And we can choose from FBS, 75-gram OGTT, random blood sugar, and your HbA1c. And we need to establish the severity or the control of diabetes with HbA1c. So when do we use an FBS versus a 75-gram OGTT? So we prefer the 75-gram OGTT in some patients. Of course, these are asymptomatic individuals, but with high-risk features such as previous IFG, metabolic syndrome, or patients with previous CVD, CAD, PAD, stroke, or at high risk for these conditions. And this is the best test because of its higher sensitivity and specificity. But for patients with symptoms, with high index of suspicion clinically, you may want just to test for the FBS. And if it already showed you the diagnosis, then you can forego your OGTT. So our patient had FBS of 182. So after establishing your diagnosis and the severity or control of your diabetes, you would like to establish some complications, both in the microvascular and macrovascular category. Aside from that, you need to look for other metabolic comorbidities. So we need to check your creatinine, urine micro test for the nephropathy. Ideally, a fundoscopy should be done. You have your neuropathy screening tools. You have your simple ECG to detect any signs of coronary artery ischemia. And you need to check for other metabolic comorbidities, such as your fatty liver, for example. So you need to order your SGPT, SGOT. You need to check for dyslipidemia using your lipid profile. Check for hyperuricemia which is common in patients with metabolic syndrome, and TSH if indicated. So for our patient, he has normal creatinine, but there's already a positive urine micro test. The SGPT and SGOT are 1.5 times elevated from the upper limit, and the patient had a high LDL and triglyceride, typical of diabetic dyslipidemia. Because we have our laboratory test, we are able to give a more detailed follow-up assessment for this patient. So the patient has metabolic syndrome, DM type 2 with microvascular complications, hypertension, and dyslipidemia, as well as the weight problem of the patient, which is obesity class 1 from the Asia-Pacific criteria. Given this complete assessment, we need to discuss with the patient the goals of our management. And these are to address the hyperglycemia of the patient, choosing the right and acceptable medications for the patient, address the risk factors such as weight loss, address other comorbidities such as hypertension and dyslipidemia, and address or even reverse complications if possible. So we need to address a sustainable lifestyle changes with proper education, emphasis on diet and exercise for this patient. So after our discussion with the patient, in the post-consult, we need to send a clear prescription and instruction for the patient. So in this particular patient, I sent medication for diabetes, for cholesterol, and for the blood pressure. However, what is missing? Patients would often appreciate if you put the indication of the medication. So in this particular prescription, I had to send another one because I failed to write the indication. And also, you need to place the proper instruction, the monitoring of the blood sugar, the future plans for these patients, such as referral to an ophthalmologist, and attach a proper diet and exercise prescription if possible. And of course, the instruction for laboratory before their follow-up. This next video is the one I send to patients if I want to train them on how to monitor their blood sugar.
Here are the steps for checking your blood sugar. Gather your supplies. Wash your hands with soap and warm water. If you are not able to wash with soap and water, use an alcohol wipe. Do not use hand sanitizers. Place a new lancet into the lancing device. Insert a test strip into the meter. Place the lancing device firmly on the side of your fingertip. Press the button on the lancing device to obtain a drop of blood. Place the testing strip against the drop of blood and allow the strip to absorb it. Read the result from the meter. Write down your blood sugar level in your logbook. Throw the lancet away in a hard plastic container or commercial sharps container.
Also, I provide the patients with general dietary instructions, and I place some notes if there are modifications I want them to follow. Like, for example, there are patients in which I need to restrict calories, or patients with kidney problems in which I want to restrict the amount of protein they're taking. And they appreciate this. It will also save your time from enumerating all the food that they can or they cannot eat, because these are the questions they ask every consult, even if you explained it prior. Another helpful tool for me is the resources for patients, such as the myplate.gov website, in which it includes all the healthy meal preparation and the maximum amount they can eat. In this website, they can take a short quiz to analyze their eating habits and patterns. And also after that, they can look into the different food groups, the limits of each, and how to make eating healthy when it comes to preparation of their fruits, vegetables, how to make grains and proteins more palatable. So I really find this website helpful for patients. So for the exercise part, I also send YouTube materials. Usually I send exercise for beginners. And those patients who are younger and with a lot of back pain, so these complaints, they benefit from yoga for beginners. And they really appreciate this kind of videos. Likewise, I send insulin injection videos for patients, glucose monitoring videos, as what was shown earlier. And you should be selective when it comes to choosing videos. Take videos from reliable institutions such as the Mayo Clinic, American Diabetes Association, Stanford University, what else? Jocelyn Diabetes Center. Our local societies are planning to have our own videos in Filipino and local dialects, I think. But while waiting for these videos, we can use these materials that I have shown you earlier. Also, for continuing education and empowerment, I ask my patient to check my page so that if there are new materials that I was able to translate in Filipino, they can read it there. And I try to make the context very easy to understand for most patients. And they really appreciate these kinds of materials. So for patients who are referred for the management of gestational diabetes, usually they already have the diagnosis. Our obstetricians will try to manage them first. But then if the blood glucose cannot be controlled, they are referred to us. Of course, the cornerstone of management is proper GDM diet. And we provide them with a list of the diet strategy for pregnant patients with diabetes. We refer them to dietitians if necessary, and there are online services now for nutrition and dietetics. We compute for their calories based on their trimester and based on their pre-pregnancy BMI. We initiate insulin or metformin or combination of two if our CBG parameters are more than 30% above target, and if there are signs of fetal overgrowth. So I think diabetes and thyroid conditions are the two most common internal medicine problems that you will encounter. But what is more important for you to is recognize endocrine emergencies, things that you will refer to the emergency room or to an urgent care specialist. So when to triage the patient to the ER. So for thyroid conditions, you need to determine if the patient is in thyroid storm. And usually the manifestations are sensorial changes, fever, and heart failure. If you want to be on point, use the Birch-Wartowski point scale. And if your score is above 25, so that is impending storm, not yet in thyroid storm, you may want to refer the patient to the emergency room or to an urgent care specialist. For myxedema coma, usually you will not get patients for online consult for this condition. But you have to recognize that there are some patients who are at risk for severe hypothyroidism. So those patients who are not educated on the need for lifelong treatment for thyroid hormone supplementation, and those who are not compliant to these medications. For diabetes, hyperglycemic crisis is, of course, manifested by sensorial changes, severe weakness, dehydration, inability to eat, persistently high blood glucose, ketones, and inability to inject insulin. And most of the time, there is a precipitating factor such as infection, coronary artery disease, pancreatitis, or other conditions that push the patient to hyperglycemic crisis. Hyperglycemic crisis is either DKA or your hyperosmolar hyperglycemic state, or HHS. The diagnostic criteria are as follows: hyperglycemia, ketonemia, metabolic acidosis, and hyperosmolality for your HHS. For your hypoglycemia, usually due to your anti-diabetic medications, level 3 hypoglycemia warrants ER management. Level 3 hypoglycemia is defined by severe cognitive impairment requiring external assistance. There is sensorial change, possible seizure, and the patient is not responsive to oral glucose. So you need to ask the relative to bring the patient to a nearby emergency room or urgent care facility. Other endocrine emergencies are endocrine hypertensive crisis precipitated by pheochromocytoma, primary aldosteronism, and Cushing syndrome. Usually these are very rare, and the manifestations are usually target organ damage from the hypertensive crisis. But there are flag signs for endocrine hypertensive emergencies. And these are young age, resistant hypertension, paroxysmal hypertension, hypokalemia or periodic weakness, possible fasces, and discriminating features. And usually, they have blood pressure monitors that warrants urgent care admission. Patients with adrenal crisis present with abdominal pain, nausea and vomiting, and orthostatic hypotension. It usually occurs in the setting of patients with pituitary or adrenal disorders, and it is usually pushed by critical illness such as sepsis and infection. These patients, if diagnosed already, should wear medical bracelets to indicate the need for steroid in times of emergency like this. Hypercalcemic crisis is unusual in primary hyperparathyroidism, but it is more common in parathyroid carcinoma, a rare condition, and the more common paraneoplastic syndromes from the more common malignancies. They present with painful bones, kidney stones, psychic moans, and fatigue overtones, but usually the sensorial changes would warrant the ER admission. I will not discuss the rare endocrine conditions, for usually these are referred to us endocrinologists. I hope the teleendocrinology pearls that I've shared to you will help you in the management of the common endocrine disorders such as diabetes and thyroid dysfunction. Let us be a game changer in our field. The world is changing, but our patients' needs remain the same. They still need a compassionate, competent, and committed care from Tomasian internists like us. Let us continue to introduce innovations. Let us deliver more than expected. And let us use our platforms responsibly. Always remember, telemedicine is not about technology. It is about people with ultimate goal to provide the best possible clinical care. The key to sustainability is investing with human factor and relationships. If you find some of the information in my lecture useful to your practice, I am glad to share it with you by downloading this presentation using this QR code. If you have any questions or comments, I would like to hear from you in the open forum, or you can email me at ericsmendoza@gmail.com. I would like to acknowledge Dr. Erick Laplano for some of the photos I used in this presentation. Again, thank you very much and good day.